Hello everybody, my name is Yahya Ethawi. I am a pediatrician and neonatologist. I work currently with Ministry of Health in UAE, and today I'm going to speak about something called Golden Hour, and it's the second episode of three episode series about taking care of a newborn baby. And in this talk, my objectives would be to define the golden hour, and maybe we can talk about something called gentle care, and what are the components of golden hour, and what is the resources, and overview, and again how it flows, and how we do the working hours. So the golden hour is the first hour of postnatal life in both preterm and term baby. Now the golden hour meaning you practice all the evidence-based interventions, procedures, and skills for both term and preterm. It started from adult trauma, where when an adult sustains multiple injury, the first hour of care is vital to prevent secondary injuries. And from that, it takes to the pediatric and neonatal care. Now, the evidence of golden hour improvement in certain outcomes, acute and chronic, are very well documented, and there is lots of body of evidence. However, in term babies, there is no evidence. Despite that, there is a global agreement between all neonatologists that golden hour should be practiced for both term and preterm baby. Now, the golden hour starts with a neonatal resuscitation, and to do the proper neonatal resuscitation, there is also prerequisite. One of the important prerequisites is the equipment, and there are multiple types of equipments need to be available to do proper resuscitation. Now, I'm not going to go through all these equipments, but they are very different. Some of the equipment, including those deal with intubation, and those with suction. Those also a list of medications that need to be available. Where there is a little bit of different requirement other than suction, intubation, and medications like warmer, like towels, monitors. And also there is additional equipment for preterm babies, extra to other neonatal stuff. Like compressed air, oxygen blenders, plastic wrap, and transport incubator. Now, to do a proper golden hour, we need a trained staff. Now, because the neonatal resuscitation involves many disciplines, therefore we need everybody to be certified with same program, so the work is fluent, and there is understanding regarding the communications, and the work is organized when we do procedures and when we document. Therefore, a special program like neonatal resuscitation program is a good one, and these people should be recertified, and their skills are up to date every 2 years, but it's not a must to be an RV. Any equivalent program is acceptable. There should be 2 skilled physicians available for preterm babies less than 28 weeks. Now, there is no problem for attendance of resident and trainee, but they should not be the sole dependent. They should be there for training and understanding. We need 2 resusc nurses, one for doing the procedures and taking the nursing care, the other one for documentation, with the RT to take care of the respiratory and ventilators and other respiratory support issues. If a respiratory therapist is not available, then an extra third nurse would be enough for having a third person to help with the doing the resuscitation. Now, the golden hour, one of it is to attend or not, to initiate the golden hour or not, and this depends on what we call it high-risk deliveries, and these are dependent on certain points from the maternal conditions, previous maternal, for fetal conditions, fetal problem, antepartum and pregnancy complications, complication during the delivery, and also there should be also procedures for babies who born in unacceptable normal conditions, but they suddenly decompensate and crash. So there should be on board code blue to be available to meet the unexpected situations, and we should be within acceptable response time. So from these high frequency, the neonatal team will decide to attend or not to attend. So we have the equipment, we have the trained staff, but we need the setting. So when we do resuscitation, it's very important to have independent resuscitation room. And the reason for that, because we have to control the environment, the temperature and the flow. We know in certain care for adult, like doing C-section or taking care of pregnancy, the temperature should be high because it should be low and reasonably maybe 20, 22 or 23, and that's not suitable for resuscitation of preterm babies because the temperature sometimes we have to set it a little bit higher, and therefore independent resuscitation room is vital. It should be linked to the room and should be linked to the operation room and should be linked to the NICU. Now the links is not too much to be like direct physical link. It can be through transport cars. I've talked already about thermal conditions and presence and organized equipment with labeled and supplies that will be easily accessed. This is an example of a resuscitation room, and you can see here the bed and the ventilators for that. You can see here that all the foams, the towels, and other supplies are tidy and labeled and organized. You can see a transport bag. Another view, you can see one more bed. You can see all the supplies are ready and primed and ready for action. You can see everything is labeled with a lot of support documents and help. You can see this is another bed, and also so we have there should be 3 beds. You can see the monitors, the ventilators, and other support machine are all ready for. You can see that also the room have different access with other communication stuff and timing. You can see this is an example of portable X-ray. You can see all the other supplies are there and labeled and organized and easily to be accessed. And you can see the transport car is also very well equipped with the ventilators, oxygen supply, transport bag, infusion, nitric oxide, jet ventilator, extra staff, and you can see it's a motorized, so there is no need for power, and you can it can move with a press of button, and no need to, and it can be drive very easy. As we said, there is an extra equipment just for preterm babies to practice golden hour, like polyethylene bags, skilled personnel for intubation, surfactant, how to take care of skin, lines, dress, and so on. Training are very important when we do a golden hour, so having a clear program to train new staff and for use and of golden hour and PM member of golden hour member. So why we do golden hour is to avoid and help tackle certain preterm challenges like hypothermia, hypoglycemia, ventilation, breathing, IV access infection, preventing damage to organs like eyes and brain, prevent acute complication like a pneumothorax, fluid, TPN, and feeding. Now, this is an example of a golden hour checklist for babies less than 33 weeks. This is a pre-checklist, and you can see certain checked items for nurses, others for nurses or RT, and a nurse can do it if the RT is not available, and certain checkpoint for physicians. And you can see those with yellow color are sent in checkpoint for those 26 weeks and less, or between 23 and 20 weeks. This after being checked and make sure that these are done or not done, it should be signed by the designated person. This is another checklist after 15 minutes of delivery to be on and timely with the golden hour at 30 minutes, certain checkup for different gestation, and at 60 minutes. Further at 1 hour, at 2 hours check, and this is a timeline procedures that should be done after birth within 1 hour, and I'm going to expand in certain slide. You can see that within 2 minutes, delay cord declamping when the decision done to make it around 2 minutes. You can see that CPAP should be started within 2 minutes. You can see that peripheral IV and dextrose should be within 10 minutes. You can see that caffeine should be started hit baby within 20 minutes. And you can see that central line should be within 45 minutes. And you can see that surfactant should be given somewhere between 30 minutes to 2 hours. And the sepsis workup and blood workup should be done within probably 1 hour or 2 hours. And you can see start with birth and the golden hours and ended with gentle care. Now, certain things like X-ray should be very well organized to be done within certain period of time. And also, we have to make sure that when the baby delivers, and if you are deciding to give the surfactant at 30 minutes, then the warming up should start, because it takes at least 20 minutes to be done. We can do another checklist for these babies according to their gestation at 2 hours. And then when we transfer, we have a specific checklist for transfer. After we're done with the golden hour, we have to do debriefing. What went well, what was the barrier for the management. If we break the golden hour checklist, what was the reason, any suggestion. And at the end, if there is a question or resources need to improve the golden hour, we need to contact our administration. So that's the end of the golden hour session, and I hope I see you in other episodes. My name is Yahya Ithawi. I'm a pediatrician and neonatology, and thank you for listening.